So I want to ask Dr. Stiles, is at least prior to the Pacific data, it was fairly frequently that I would see patients in which they would have stage 3 disease. The surgeon they saw wasn't wild about operating on them at that time, but then they would say, well, let's give them some chemo, let's give them some radiation and see what happens, which to me is a treacherous strategy. My training was decide if surgery is going to be part of the treatment up front, and if it's not, then it's probably not likely to be part of the treatment out back. So I just wanted to get your thoughts on, has this changed that at all, or do you find yourself reassessing patients if they have great responses either to chemoradiation or to immunotherapy?
Yeah, it's a great question. I do think it's a pretty treacherous area, though. I tend to agree with you, and I know that all of us surgeons, for the most part, do. We think these are decisions that should be made upfront with the multidisciplinary tumor board and the radiation oncologist and try to decide a priori. It can be challenging decisions without a doubt. I think we know that chemoradiation from the trials, intergroup trial, 1601, has a relatively low complete path response rate, less than 20%. Even if you push it to higher dose in the RTOG studies, 0229, 0839, although there was a great rate of mediastinal nodal downstaging, the CPR at surgery was still relatively low, around 25%. That's with the caveat that there may be ongoing cell kill and it may get higher as they get farther out. But also, I've been struck, if you look at the Pacific data and you look at the failures, 85% of progression was in the chest, either in the lung or in the lymph nodes. Some of that may have been new lesions in the lung, but clearly there are issues or times when local regional control could be better. It's a challenging place for surgeons to get good local regional control as well, though. And so again, to me, it often comes to that idea, trying to decide up front. Most of us don't believe that you can take any of these drugs and make a patient who's unresectable resectable. I think that's a fallacy to go down. And sometimes with immunotherapy, it can be even more challenging.
That's a great perspective. One of the other issues I wanted to address, and I guess it's to all of you, is obviously the Pacific strategy was a consolidation strategy. Is there rationale for, I'll pick on Kristen first, is there rationale for concurrent use? And then I'll ask Stephen and Roy to chime in on, should it be part of induction treatment prior to radiation? So Kristen, your thoughts on moving it up earlier?
Sure. So I do think that there's great preclinical data demonstrating radiation and immunotherapy synergy. And there are a multitude of trials that are testing concurrent immunotherapy now in the stage 3 unresectable setting. We did see some interesting data at ASCO. Dr. Salma Jabbar presented some preliminary results from Keynote 799, which is a trial of concurrent immunotherapy. It's a non-randomized phase 2 trial where there were 2 cohorts of patients. The first cohort got concurrent radiation 60 gray with carbotaxol and pembro. Second cohort got cis-pem 60 gray and pembro. The primary endpoint of this trial was overall response rates and grade 3 or higher pneumonitis. And not unexpectedly, the response rates were very good, a little bit better in cohort A, 67%. And the pneumonitis, high-grade pneumonitis rates were also manageable, between 5 and 8% for both cohorts. Now, the follow-up isn't long enough to really give any survival or progression-free survival data on this trial, but nonetheless, I think it is encouraging that perhaps concurrent immunotherapy could be a strategy in the future.
And then Stephen, role of induction.
Sure, I think that we're still trying to best work out how immunotherapy and radiation work best together in a patient with lung cancer. And they're not additive. We're not looking for additive benefits. We're really looking for synergistic benefits, and the effect that radiation has in the microenvironment and the effect that chemo has in the microenvironment, and the effect that the immunotherapy and radiation work together. Do we need to give them together or in sequence? Helen Ross at ASCO presented an update on one of the alliance studies, AFT16. and it's an early look at about 64 patients. But in that study, he received PD-L1 inhibitor atezolizumab first, just by itself. They did an early look to make sure patients weren't progressing, completed 4 cycles, so 12 weeks of just PD-L1 inhibitor, so really an induction immunotherapy approach, then followed by chemoradiation at that point. And they looked at disease control rate, and it was high. But really, these different strategies, what's going to determine which is the best way to go is which approach leads to more long-term survival, which approach leads to more cure. And right now, we have disease control rate, we have early responses, we have landmark PFS rates, but we don't have what that 3-5 year tail will be. And I think that's going to help guide us more so. We also saw in that Alliance trial, there's a little bit of toxicity. While it was relatively well tolerated, we did see some grade 3 tox, 1 episode of colitis, 1 episode of Guillain-Barré syndrome. And if we're looking at strategies that maybe jeopardize the definitive or curative treatment, be it surgery or radiation, that's something we have to look very closely at.
Yeah, Roy, your thoughts there, and then your thoughts on the immuno combos like CTLA-4 added to this scenario?
Right, well, my first thought is, you would want to move immunotherapy as early as possible because, the tail on the curve is clearly there for some patients, and you're getting into them earlier and can only be better. That said, we can't forget, that before recently, our curative therapy in lung cancer was chemoradiation in patients who are unresectable. So we want to make sure we don't compromise giving those full doses of chemo and radiation. But if immunotherapy can be given concurrently and there are no toxicity issues and full doses of those drugs can be given, yeah, I'd say go ahead and do it and give the immunotherapy more time to work. As far as combos, immune combos, that's again, if you don't see activity in the metastatic setting, I'm hard pressed to want to bring it forward, with the added toxicities of a combo to the early stage curative setting. So certainly can be tried, and neoadjuvant approaches are good ones. We'll talk about that in a bit, because that actually gives you the ability to biologically look at what's happening and understand resistance, primary resistance. But I'm not that enthusiastic.